Hello, and welcome to our discussion on revenue cycle and really some business intelligence that we're going to be using or that we're going to be able to utilize with some of the documentation that has occurred that we've seen over the past 4 or 5 modules. So clinicians are actually documenting patient occurrences and what's going on with them, whether they have needs for procedures or catheters, IVs, dressing changes, medications in the pharmacy, lab, and more. This information is pulled in and is utilized to for acuity for staffing, for example. It could be utilized for DMA, durable medical equipment resource allocation for like X-ray, pulmonary function test, CAT scan, CT, the MRIs. So those are all things that are pulled in, and that information is used to aid the facility in allowing its resources to be utilized in the most cost-efficient method. One of the other things that it does is it helps with throughput. And throughput for a hospital is extremely important. Every day, almost every single facility is going to have what's called a bed briefing. Now, it might be called something else in your facility, but that's where everybody kind of gets together, all the managers kind of get together and figure out who's being discharged, who's being moved, who's being admitted, and kind of looking at the data that they have to determine how patients are flowing through the hospital. Now, it's very important that you recognize who the actual customer is of any given hospital. If you ask the CEO who their customer is, it's really the physician. And the reason is because patients typically don't choose a facility unless it's underneath their insurance, and they don't choose the insurance unless it's with the doctor. Now, they could choose an insurance and have to change doctors, and that's a complete pain. But ultimately, the doctor is who drives the patients to the hospital, depending upon where their admitting privileges are or their practicing privileges are. But the CEO's job is to make sure that their customers are happy, because ultimately, regardless of what business you're in, your job as a CEO is to drive revenue. Number two, you're also supposed to ensure profitability. So part of the reason that the doctor is so much the customer in this situation is because the CEO's responsibility to drive revenue. The CEO reports to a board of directors, and the board's job is to make sure that the shareholders or the stakeholders are happy, that they're providing value to those shareholders. Now, in a for-profit hospital or healthcare organization, healthcare system, it's pretty easy to see who the shareholders are. They actually hold stock certificates, or part of the stock certificates are being held in mutual funds that people are investing in. Those people are looking for positive returns. In a nonprofit, the stakeholders are not shareholders, but at the same time, the stakeholders are actually the community and the hospital itself, because as a nonprofit, you still have to make a profit. And that's one of the misconceptions that's out there, is that if you're a nonprofit hospital, that's okay for you to take poor and indigent patients because you're not supposed to have a profit. That's not what that means. What nonprofit means is the fact that they don't pay taxes on the profit, because the profit is then turned back into the organization to help fund additional initiatives, upgrades to equipment, upgrades to facilities, purchase additional hospitals or ambulatory centers, certainly for salaries. So to have that happen, every hospital has to make a profit, even if it's considered to be a nonprofit status. When we talk about throughput, getting back to that, we really want to get patients through as quickly as possible. But we also have to make sure that there's a quality of care that's provided, because we don't want to have readmissions. And when we take a patient through their hospital stay and we actually discharge them, the thought is that we've provided enough quality of care with enough follow-up. And again, this is where kind of the accountable care organization comes in, is that they're going to be followed up at a clinic as well as so that they don't come back into the hospital. Because if they're readmitted within a certain specified number of days, depending upon what their morbidity is, then the hospital actually eats that additional admission. Because 2/3 to 3/4 of the hospital's finances actually come from reimbursement from usually CMS or Medicaid, that's where they want to make sure they don't have readmissions any more than they need to. The other thing that kind of information can help with is also with durable medical equipment. Where is the DME? What's the service cycle of it? Is it an annual service where something in service isn't more frequent than that? What about the battery? Is the battery need to be replaced? So beds, when do beds are going to be replaced? Those are all capital expenses that have to be accounted for, and the information that is gleaned from the system helps organizations to better manage their DME. Same thing with some of the tracking mechanisms like RFID. And again, this is part patient throughput. This is also part asset management. So you might have an RFID tracker on a bladder scanner because one floor happens to hoard all the bladder scanners, or even more frequently, maybe IV pumps. Why do they hoard the IV pumps? Well, because they might need it when they have an admission. But on an organizational standpoint, if one floor has all the IV pumps and another floor needs them, where are they? And that's where some of the RFID tracking comes in, is the fact that we not only know when to service these pieces of equipment, but also that we have an idea of where these pieces of equipment are located. Now, at this point, I'm really kind of going to go over to the revenue cycle side of things. And, again, the thing that you have to understand is that a hospital is a company. It is a company that has a profit and loss. It has a balance sheet. It has revenue that comes in. It has expenses. And, of course, it has a net income, hopefully positive net income. It also has that whole assets versus shareholder value or shareholder retained earnings. So they have the profit and loss and balance sheet just like any other company does. And revenue cycle management, specifically in healthcare, is often complicated by changes with insurance contracting, with the insurance products that are offered, and the terms with which they operate. So from an insurance standpoint, the hospital wants to get the most amount of reimbursement for different services, and the insurance company, because it also has shareholders and stakeholders to account to, want to pay the least amount possible. If they can't come to an agreement, then that hospital won't accept that insurance. How does that impact us? Well, if you have Blue Cross Blue Shield and Blue Cross Blue Shield can't come to an agreement with Mercy, and Mercy won't accept Blue Cross Blue Shield, you're not going to Mercy for a procedure unless you're paying out of pocket. And typically expenses are high enough that nobody really wants to do that. So it's incumbent upon us as a healthcare organization to realize that we have to negotiate with these insurance companies to provide a fair service for a fair amount. But it's also in the insurance company's best interest to make sure it has hospitals, because who wants to buy an insurance policy and have nowhere to go? So there's certainly a dynamic that's involved there with the negotiation where there has to be a win-win involved, where the hospitals are making enough profit, but the insurance companies are also not incurring enough or too much of a loss that they're actually making their shareholders happy by having a profit as well. The insurance-related charges are somewhat fluid, but mostly involve these tactical daily activities, including like claims preparation, billing for services, and accounts receivable. And in spite of these changes, or challenges, these patient-provider visit process hasn't really changed very much over the years. And it generally involves how much, who, what, when, and where of the procedure and diagnostic experience. And the data that's derived from these visits is relatively static, yet the volume of data is increasing due to the overwhelming increase of medical visits associated with the aging population and baby boomers. So as we're going through this, through history, we're finding that more and more people are being admitted to hospitals because they're getting older. As I mentioned before, in many business contexts, follow the money, it really is relevant, and this is no different. Again, we're a capitalistic society, and healthcare is provided through an extremely complex environment of procedures and codes and diseases and materials and tools, facilities, as I mentioned before. And those contractual relationships between the providers and the insurers, the suppliers, the government, employers, they're at every level. In turn, healthcare providers at these levels must document and report services to payers. And again, that's where it comes, that's where the electronic medical record and the data that the clinicians and the end users are actually producing really comes into play. It's interesting because when you have the insurance companies coming through with some of their requirements, sometimes CMS jumps on board and they also start to require that. But even more frequently than that, you'll see that CMS will have a requirement and the insurance companies will say, that's a good idea. And of course, anything that comes from CMS is going to end up driving down costs. It's our job as a healthcare organization is to find value in that and also to make sure that the quality of care is acceptable. Another issue is that the overabundance of uninsured patients. They still need to be processed. And the bureaucracies and the administrative requirements around that are unimaginable. They're very intricate and sometimes very unnecessary. But, it's just another inefficiency of the U.S. healthcare system. But at the same time, hospitals still have to manage these procedural requirements and these reporting requirements, regardless of whether or not they're getting paid. So, like any other organization, we have to have some sort of predictive revenue stream. And we need to have it somewhat accurate to stay financially viable. It's very challenging for healthcare organizations of all sizes with this situation. And one of the things that has occurred most recently is the introduction of ICD-10. Now, I'd mentioned back in the 90s that HIPAA kind of came around, and that's true. And we didn't really understand what that meant as providers. But that was also back in the day that our charge capture was basically, at the end of the day, you'd see nurses walking around with little pink stickers on their scrubs, and we would have a charge sheet in each patient's room. So if we went and got a Foley catheter, we'd peel the sticker off of the Foley, and we would stick it on the charge sheet for the patient, and then we would perform a procedure. Well, we're not really thinking in the lines of managing resources as nurses. We're really kind of focused on the patient and taking care of that. I don't care if it takes me 3 or 4 catheter kits to finally catheterize that patient. But what I'm not really thinking about is whether or not that patient's being charged appropriately. And again, walking around with those pink stickers, whose pink sticker goes where, you do the best you can, but in the end, who cares? And that's really where we have what's called charge leakage. Charge leakage is when there are charges that should have been charged for a visit, but somehow aren't because of whatever reason. That's been tremendously aided by the fact that we're doing electronic documentation and the fact that we're actually have software that's available to healthcare organizations where they can look at procedures and figure out what items were actually used. Now, of course, you can also plug into like the pharmacy system or X-ray or what have you and actually document actual charges. And with the medication administration, with the electronic barcoding, we have a much better idea of what has actually gone into the patient in addition to the documentation. So there's several different fail-safes that can be triangulated to determine what the appropriate charge would be. And that's really helped to shrink that charge leakage. The charge shrinkage is sort of when stuff just disappears and we have no idea where it went. Again, it's not quite as prevalent as it used to be, but it's still an issue for organizations. And, occasionally you just, grab forceps and you take them home and just have them. Well, somebody had to pay for that. And it's the organization that has to pay for that, and they have no one to bill. So even though people don't really think of it as being theft, it's no different than stealing office supplies. But, again, we don't have that mindset being nurses that we are stewards or clinicians, that we are stewards of the hospital's resources. As such, even administrators are stewards of that. So continuing education will also help. Again, because of the software, we can have an increase in our charge integrity because we have that data to mine and to pull information from. We can use the data to look at root causes and spot trends if there is a particular trend of missing information. Maybe it's workflow issues, and again, training or other things that end up with mischarge capture. Traditional healthcare charge capture really involves reviewing those claim submissions and flagging potential mischarges, but we're getting much better at that with the introduction of data and being able to use that. So in addition to the contracts and payers I mentioned earlier, the other big impact was ICD-10 versus ICD-9. So ICD-9 was kind of an antiquated system of charging, and ICD-10 came along and literally tenfold increase in the number of of codes that were required. And on the average, with the admission of the patient and taking care of them, we then have the middle of actually documenting some of these things, and then at the end of the revenue cycle is going to be where we're trying to collect for that. So in that middle part of the charge, that's where you saw an increase in workload, sometimes 50 to 65% increased workload because of so many charge codes during this situation, this period of time between ICD-9 and ICD-10. That's one of the reasons why RHIAs and RHITs were so hot. Getting that certification, going to school for a 2-year degree or for a 4-year degree and getting that certification, you guaranteed had a job, because hospitals were just drowning with the amount of work in the middle of that revenue cycle of billing all those charges. Now, the front end charge, the patient, access and some of the pre-certification, the admissions, that wasn't too bad. The back end of it, collecting, again, wasn't too bad, although we'll talk about that in a minute. But the middle was what was really impacted by ICD-10. So talking about the back end of the revenue cycle function, the two major categories are that the billing processes for cash collections and reimbursements. So on the one hand, we're submitting claims to insurance companies or payers and getting reimbursed on those. And the other hand is the patient responsibility. And, when we're talking about, and some like denial management, when we're submitting claims, is that they get denied, so we need to process that and figure out why, and then ultimately try to get that paid. But the cash collections, that's where we're seeing an increase in the number of cash collections, because a lot of people are out there are having a lot more responsibility for their own individual healthcare policy, because the cost has been shifted from the employer to the employee. And now I have to look at my policy. Maybe I have a selection of a few of them, and I have to determine how I'm going to spend my healthcare dollars. Now, when you go to a service station to get your car looked at, they have the prices pretty much posted there. And they might have some flexibility or wiggle room, but those are the prices that are posted. Healthcare's never been like that. Because if somebody were to say, how much does this service cost? Well, it depends. Because it depends upon whether or not it's a government patient, because that was a negotiated rate. If it was an insurance patient, that was a negotiated rate. Which insurance patient? Because multiple insurance companies might have multiple rates charged to them. And then there might be a cash price. And that cash price might be discounted for cash payment. So there really was no, how much does this colonoscopy cost? In addition to that, you have sepsis. You have a facility fee. You might have a medication fee for the anesthesia, an anesthesiologist, as well as the actual doctor who's performing the colonoscopy. So you might have 4, 5, 6 different charges for that one event. It's almost like you would go to an auto body shop, and you would have a different charge for the shop charge. You'd have the paint charge. You'd have the charge for whatever it costs to fix the vehicle. There'd be an additional charge if new parts were required. And all those are separate, and they come to you at different times. Huh? That doesn't make any sense. Healthcare is really one of the few industries where that has been the common practice. However, as some of you have read, CMS is now requiring that hospitals post publicly what their charges are. Your charge master is what it's called. So that's going to be very important, because that will help patients determine where to get care. It will also help to figure out what doctors to use, what insurance companies to use, because what hospitals take these different insurances. Again, this is much more a move to consumerism, the patient portal. The patient portal idea has been around for several years. Certainly part of meaningful use was that patients had some sort of visibility. But the actual getting of patients to log in and interact with their own information, this was a foreign concept to most people. Only now are we starting to see where patients are actually contributing to their medical record, in actually employing these different devices, the patient portals, to access to go ahead and schedule appointments, to go ahead and make payments on bills that they have. And we're so used to paying things online or on our phone. Why can't we do that with our medical bill? I'd much rather slide left and pay $25 towards a $300 charge, or pay the whole $300 if I had access to it on my phone or online some way. So we'll talk a little bit more about consumerism and the push towards that. But the end part of revenue cycle and some of the things that you'll be reading about the trends in 18 and 2019 is that push for, with the consumerism in mind, of ways to be able to recoup payment or to bill patients. That has not really traditionally been the way that billing departments have worked. So this will be, again, a driver for the next module that we'll be discussing with consumerism and marketing in healthcare. But on a side note, I wanted to talk a little bit about a company that I started, and I'm going to go ahead and have that as a lecture B, a second lecture, and we'll talk a little bit about that in the next lecture. So thank you very much. A little bit of reading this week, but keep working on those final papers. Thank you.